Good evening. I'm Dr. Manoj Goel. It is indeed a pleasure and honor for me to welcome you to this TB Guardianship Certificate Program endorsed by the Indian Chess Society in partnership with National Tuberculosis Elimination Program, USAID, International Union Against Tuberculosis and Lung Diseases, and Corporate TB Pledge. And this academic activity is being supported by CIPLA and BD, and we are highly thankful to them. I'm also thankful to Dr. Sandeep Salvi, the President of Indian Chess Society, Dr. Amita Nene, Chair TEI, ICS, and Dr. Rajendra, who is the Secretary of Indian Chess Society, for giving me this opportunity to moderate this academic program today. It's a great responsibility and trust and honor which is bestowed on me by the senior committee of the Indian Chess Society. Actually, I would be just facilitating the discussion. We have got a galaxy of the experts and I can't moderate them. It's beyond my capability and capacity. But I welcome all the galaxy of experts from all over India. It's indeed a pleasure to welcome you all, sir and madam. Now, coming to the topic, TB management continues to be a challenge even in this modern period. There is a slide projected. So can you just a minute? There's some disruption from my side. Yeah. So as we know, the TB management continues to be a challenge even in this modern period, despite the availability of advanced rapid diagnostic facilities and very effective anti-tuberculosis therapy. In this session, we will try and navigate you through the difficulties in the management of tuberculosis with special emphasis to complex clinical cases, extrapulmonary tuberculosis, and end here with our galaxy experts who are here with us. So I once again welcome all the esteemed experts to this certificate program. The agenda of the meeting today is quite vast. We shall try to address almost all the complex scenario in TB diagnosis management, which we face routinely in our clinical practice. We'll have two case-based presentation on difficult scenario in MDR TB, followed by a panel discussion in which we'll try to find answers to about 20 to 25 complex situations in tuberculosis management. So without much ado, I would first invite Dr. Bornali Dutta to please speak on difficult to treat scenario. Dr. Bornali Dutta is Director, Pulmonary Medicine, Respiratory and Sleep Medicine at Medanta. And she is a very big name as far as the tuberculosis and pulmonary medicine is concerned. She is the flag bearer of tuberculosis control program in Haryana and is always shows us the path how to move forward in this, pious, activity. So I would request Dr. Bornali Dutta to please go ahead with her talk.
Thank you, Dr. Manoj, for this very kind introduction. And I'm very privileged to be a speaker today in this very good session on TB. I'll just screen share. I hope that's visible and I hope I'm audible. So
yes, ma'am, you can go ahead.
Okay, so I'll just whiz through a series of difficult to treat TB case scenarios that we all encounter on a fairly regular basis in our clinical practice. And I suppose the first question is, what is an easy to treat TB case scenario? So, is there any such thing? So the easy to treat would be, I suppose, a drug sensitive pulmonary TB patient who has a predictable, predictable absorption of the drugs into the lung, a predictable response, and therefore outcome. And that would be a straightforward case. But then, as we all know, it rarely is so. And so let me go ahead with the cases that we encounter. So the first case is a 15-year-old young woman who first presented in February 2023 or rather was diagnosed in a different center with pulmonary tuberculosis and started on HRZE. I mean, that's all the information we have. Almost 6 months of treatment and then came to Medanta with persistence of fever and developed acute breathlessness. She was now nearing the end of her consolidation phase. The treatment that she was on was a fixed dose combination and she was on 2 of those tablets, and the total dose was rifampicin 300, isoniazid 200 with a body weight of 30 kilograms. So this is where we started with. And then this is the X-ray she came to us with. As you can see, extensive consolidation bilaterally with a left lower lobe pneumothorax, which was then intrathoracic drain was put in and drained, and the consolidation is quite significant. Bronchial washings done on the 8th of July detected medium Mycobacterium PCR, and rifampicin resistance was not detected. XDR done at that time also showed no drug resistance of isoniazid, fluoroquinolone, or the injectables. This was 2023, at which time we had procured a 10-color expert XDR machine. So we continued ATT at that point. We also did rifampicin levels, which has again been a recent procurement for us, maybe for the last 1 year. And the 8 to 24 is the therapeutic range, and her levels were 4.88, so subtherapeutic, and her rifampicin dose was increased to 450, which anyway needed doing as per her body weight. Isoniazid increased to 300. We didn't have isoniazid levels at that testing at that point, so we didn't do that one. So she left and then returned 3 weeks later, unwell fever with a recurrent left-sided pneumothorax. So we went through the same process again, and it really seemed like a setback. And we, felt, why had we not been able to manage her so that she didn't come back with this, with a recurrence of this. Rifampicin level at that time of presenting the second time was 8.49. So just about entered into the therapeutic range, but clearly still unwell and without response to this increased dose. So we increased the dose further to 600. Isoniazid stayed at 300. 10 days down the line, when we checked the rifampicin levels, we found it had become 17.6, well into the therapeutic window. And so she continued on 600 and 300. This is again shortly after her discharge, one X-ray, where at least the pneumothorax had resolved, and hopefully these consolidative patches will slowly get better with time. And then she did recover from this and has not had a problem ever since then. So therapeutic drug monitoring. Now, while I chose the first case to be that of pulmonary tuberculosis, all of us are aware that sometimes what can be really challenging are the extrapulmonary TB cases, especially the lymph node cases, the possibacillary ones, where you don't have a kind of predictable response. Drug penetration is poor, and therefore one doesn't know how to deal with that. So coming to one such case, again, a 17-year-old girl who was treated for cervical lymph node in the national program. So she received 3 consecutive years, she received ATT. So 2015, she received it for 6 months. Treatment was completed every time. 2016 for 9 months, 2017 for 9 months again. Each time she came back, her AFB stain and culture was positive, and it was always a pan-sensitive AFB. So this was where things were when she came to us in 2019 with enlarged lymph nodes and fever. So at that time, we didn't have any of the drug monitoring facilities. So we sent it to Hinduja in Mumbai, and the rifampicin was within the therapeutic range, 9.5. And this was the isoniazid, which was well below the therapeutic range of 3. So again, she was on a fixed dose combination, isoniazid 75, rifampicin 150, and ethambutol and pyrazinamide. She was taking 3 tablets, which brought the INH dose to 225, and an additional 100 milligrams was added to this. So again, she progressed well. She recovered, and her lymph nodes certainly settled. December 2019 was the start of treatment. Lymph node size, the cervical lymph node was 2.7 into 1.3 centimeter on ultrasound. And in September 2020, at the end of treatment, the lymph node size had reduced to 1.3 into 0.5. So we think she was cured because she didn't come back to us, and we feel the therapeutic drug monitoring played a very key role in resolving the problem for both of these patients. Now, a word on therapeutic drug monitoring. Now, what causes this low level? And this is something that we weren't so aware of or checking that regularly in the past, but now we are very much aware of this problem that results in subtherapeutic doses, and therefore the efficacy of the drug is not there, and therefore the cure is not there. So it can be poor quality of drugs, it can be poor compliance. We know that very well with TB. And then it can be significant problems like malabsorption of some sort, drug-drug interaction, age, ethnicity, gender, pharmacokinetics, and then comorbidities as well play a significant role, like HIV, diabetes, GI disorders, etc. So a quick mention of what is there in literature. And if you look at the rifampicin TDM studies worldwide, some of the studies show a staggeringly high percentage of population with subtherapeutic levels of rifampicin. So 70, 80, 90%. So that's really very high. And then it is no surprise that, TB continues to be, an epidemic and such a menace to us. What about our Indian studies? So we find in this, the 100 patients, 59% were in subtherapeutic range, and 50% of the population were partial responders to the therapy. So this is where we are at, that without the help of drug monitoring, therapeutic drug monitoring, we really can face a problem in a significant number of patients, and we have to be very cognizant of that. So this is the where it peaks, as we know, roughly in 2 hours, and this is where the sample is taken for rifampicin and for quite a few of the other drugs, although some have varied timings as well, but that's where we match it to. When is the time that it peaks? Because that's when the bactericidal action happens. And then there are many other things to it, which I won't go into specifically. But apart from TDM, when there is no response, also worth thinking about the site. Now, pulmonary, as we know, has the best penetration of the drugs, and any other extrapulmonary site is not as good. CNS is a special situation where specific drugs penetrate well and many don't. And that needs to be borne in mind, that even though therapeutic drug levels are fine, the response may not be as expected. And then lymph nodes, as we discussed. So now moving on to another set of problems. Case 3 is a 40-year-old lady who presented in 2021, May 2021. Now, she has a history of psoriatic arthritis on methotrexate, sulfasalazine, folic acid, also history of extrapulmonary TB, pleural effusion in the past, and had received tofacitinib in the past. And as we are all aware that in these rheumatological conditions, these immunomodulators are notorious for converting latent to active TB, and we have to be, again, very wary of this. She presented in May with fever and neck nodes, and FNAC of the left cervical lymph node was done. Now, this is the result we had. MTB detected low, and there was no rifampicin resistance. Cytology from the FNAC showed epithelioid cell granuloma, as well as a few AFB were identified. So that was a clear-cut diagnosis, started on ATT, HRZE, and sent away. Came back in July 2021 after 2 months of having taken the treatment, with a sudden increase in the lymph node size, which was now red and fluctuant. A repeat aspirate was taken for gene expert and culture. So this is the appearance of this. As you can see, it's quite red erythematous and looks quite boggy. On completion of 2 months, there was clinical improvement, and apart from the fact that this lymph node had suddenly increased in size and had this appearance. So in the repeat aspirate, again, it was detected low with no RIF resistance, and the culture that was sent at that time in 8 weeks down the line showed us that there was no MTB growth. So this, then drug levels were also looked at. Again, this was sent outside to make sure that we, had covered all the various aspects. And as you can see, they were within the therapeutic range, rifampicin very much so, and isoniazid as well. And so this brings us to the concept of paradoxical reaction. And we're all aware of this immune response to, to the treatment of mycobacteria, where the mycobacteria, once it starts dying, it just triggers a hyperimmune response in the body that first causes a flare-up of the original illness before settling down. So it's an immune response, not an infection response, not a worsening of the infection. So it can happen in as much as up to 20% of patients between 3 weeks and 4 months of initiation of treatment. Cultures are typically negative and they do not indicate treatment failure. It has to be recognized as such. This has been attributed to an immune response to the dying MTB organisms, and the manifestations, as we saw in this very beautiful photograph, is a lymph node enlargement with fluctuance and erythema. The differential diagnosis, of course, is treatment failure due to drug resistance, non-compliance, other infections or other causes, and these had already been ruled out by the FNAC that was taken. So the treatment is steroids for this, and this lady recovered completely after the correct treatment. And later, when she had a ultrasound neck and thyroid, there was no evidence of deep cervical lymph nodes. So this is, of course, sometime later. But she recovered and did not need to be relooked at again. Fourth case is a 19-year-old woman who presented in Jan 22, or rather was diagnosed outside again, with a smear-positive AFB stain 1+, gene expert MTP detected low with no RIF resistance. Started on HRZD, and then a month later came to us because her fever was persisting. So again, her sputum sample in this case detected low with no RIF resistance, and smear was negative. She was discharged on HRZD with appropriate, the dosing was made appropriate, and she was discharged. The patient, however, continued to have persistent fever, ongoing weight loss. X-ray became really bad, and she developed, again, one more case of pneumothorax. A month later, in March 22, she came back to us and was admitted. So this is her X-ray, again, very extensive lung involvement and pneumothorax. Now, AFB stain was, again, we went through the entire sputum testing. AFB stain this time was positive 1+, and gene expert detected medium with no RIF resistance. But this time, because of the AFB positive, we had line probe assay. And here we can see that sensitive to rifampicin, but resistant to isoniazid. So as you saw, we couldn't do this the first time around because smear was negative. And therefore, we lost out on this chance of detecting isoniazid resistance and thereby fine-tuning the treatment. So these are sort of, near misses. And if this is the kind of problems that we face sitting in tertiary care centers, then I can imagine that in places where there is no access to this level of diagnostics, how difficult it must be for clinicians to pinpoint the correct diagnosis. But at the same time, that is vital for for tailoring the particular treatment for that specific patient. So this is isoniazid monoresistance. And again, at that time, we didn't have XDR in our hospital. Otherwise, that would have been an option in the absence of a smear positive in the first presentation. So then the regimen was changed and levoflox was added on, and she continued for 6 months and recovered very well. And this is a current X-ray from the last follow-up that she had, with just some fibrotic strands from the extensive kind of lung consolidation infiltrate that she had. So drug resistance, I won't talk about it because I know Dr. Anuj, who is very much the expert in this, will be telling us much more. But just to point out that in the current day and age, drug resistance is something that we don't typically miss out on, because we all are fortunate to have access to a lot of the entire armamentarium of diagnostics. However, sometimes these slips happen because of the limitations of each test. The fifth case is slightly different. Again, there's a whole basket of cases where there are other system involvement: chronic liver disease, chronic kidney disease, pregnancy, etc. So many. So I'm not going to delve into that because I don't think we have that kind of time. But nonetheless, 44-year-old man, post-renal transplant, 2021, and as we know, all of them tend to be on tacrolimus, which is to prevent acute rejection. So 2021, and this is just a screenshot of the levels of tacrolimus, which is monitored very closely. Presented to us in April with fever and cough, and the chest X-ray was abnormal. I don't have the film, and sputum testing was done. Now, in this sputum testing, again, detected low on gene expert, RIF resistance detected, and then in the XDR, isoniazid detected, fluoroquinolone detected, and in the culture that eventually came through, it was pan-resistant to all first-line drugs. So this is there's a pre-XDR patient that we are dealing with. So ATT that was started then then consisted of a completely different regimen, which is bedaquiline, linezolid, clofazimine, cycloserine, delaminate with high dose of pyridoxine. And this has been treated by the DOT center for the patient. So this is, he's responding very well to it, and there has been no problem with tacrolimus. But I suppose the point that, to just highlight is that the fear is rifampicin in these cases, because rifampicin, as we know, because of stimulating the liver, the enzyme metabolism, often renders other drugs, almost the levels negligible in the blood, and that can lead to quite significant consequences. In renal transplant patient, it can increase the chance of rejection if tacrolimus levels are not therapeutic range. And on the other hand, in the absence of rifampicin in the drug regimen, we know that the TB treatment, the regimen is not as effective. So it's balancing the two, and often rifabutin is used as an alternative, fluoroquinolone is used as an alternative, and sometimes people even have reported increasing the dose of tacrolimus quite significantly as some of the options that are used. So while the patient who I've showcased is not really has this problem, he's got pre-XDR, and therefore rifampicin is not in the picture. But just to bear in mind that drug interactions in other system diseases is quite a significant thing for us to watch out for. And then the final case, this is a 48-year-old man who had full treatment of MDR-TB with second-line ATT in 2021, January to October in the national program again, and had a second round again in 2022, March. This was started as the sputum but sputum was gene expert positive, and on the basis of that, they had started on the appropriate treatment. This patient came to us in July 22 with hemoptysis, and initially underwent an embolization procedure, and then again came back a month later with hemoptysis. His CCT showed a fibrobronchiectatic left upper lobe, a large cavity with aspergilloma, and pseudoaneurysm as in the angio. And you can see in this that the left upper lobe is, as cut sections, you can see clearly the aspergilloma with the crescent sign, and then the cavity with a shaggy, thick wall, a lot of infiltrates, and the upper lobe looks really quite damaged. And then this is just the mediastinal window showing the same thing with the crescent sign. So this was referred to the surgeons, and the left upper lobectomy with S6 segmentectomy was done. And this patient, again, recovered very well. I don't have a follow-on X-ray, unfortunately. But this then brings us to the fact of, this is the actual, the lung surgery, the post-surgical histopathology, and this was entirely compatible with aspergillus, and there were some reactive lymph nodes, and there was no MTB growth. So this was just a post-tuberculous cavity, but because the gene expert, as we know, often picks up dead bacilli, and so this cycle just went on, and removing that destroyed lobe with the aspergilloma was probably the best way to deal with this situation that the patient was in. So some of the indications of surgery in TB, now we're all aware that essentially TB is medical treatment, is antituberculous treatment. That's what it responds to. But certainly surgery plays a role in certain very specific scenarios. One of this being this patient that I presented, MDR with the focus of pulmonary TB activity located in a part of the lung, a segment, a lobe, or one lung. And if that is removed, then the entire burden of the disease is removed, and the drugs will work much better, and there is a greater chance of cure. Pulmonary aspergilloma, this is something we all face, and we know the treatment for this is only surgical, and any tuberculous cavity often gets essentially colonized by aspergilloma, and this is a high risk of hemoptysis, sometimes even life-threatening. So in the scenario of TB, post-TB, this is, again, surgically resected. Sometimes bronchiectasis, which can be post-tuberculous sequelae, can also be ongoing tuberculous illness. There can be destroyed lung, massive hemoptysis, recurrent infection, bronchopulmonary fistula. These are all indicators of surgery in TB in the correctly selected patient. If the patient's selection is appropriate, then they do very well. They do very well with the surgical intervention. This is more for children, mediastinal tuberculous lymphadenitis producing compressive symptoms because they get much larger lymphadenopathy and their cartilage and everything is ill-formed at that stage. So surgery in PTB that do not respond to medical treatment are serious and potentially fatal. So this is something to remember and utilize for patients who warrant surgery. So with that, I come to the end of the discussion of these cases, and I acknowledge the team, Dr. Pinky Goel, Dr. Ashish, Dr. Jaiswal, Dr. Parinika, who helped me get this together. So difficult to treat TB cases in our day-to-day. I suppose these are the broad categories to look out for. Inadequate drug levels, paradoxical reaction, undiagnosed drug resistance. We'll hear much more about that now. Transplant and other system patients and surgical management, those who do need. And that's when our medical acumen has to come in when we need to refer on to the surgeons. Thank you very much for your patience. I will stop sharing.
Thank you, Dr. Bornali, for sharing some very interesting cases, highlighting the value of monitoring the therapeutic drug monitoring, paradoxical immune response in lymph node tuberculosis, the treatment failures, the isonized monoresistant TB cases, pre-XDR TB in immunocompromised host, and also showing some of the sequelae of the tuberculosis, particularly that wonderful case of aspergilloma, and most impressively, the role of surgery in tuberculosis, which, in many centers is, forgotten. And there are a few cases where we need to involve the surgeon in our therapeutic workup of these patients. So I once again thank you very much. Thank you for this wonderful presentation. And I would invite Dr. Anuj Kumar Bhatnagar to present his.
May I come up for a second?
Yes, sir.
Ask the Bornali one thing, very interesting cases. Now, in one case where there was paradoxical reaction and quite fluctuating lymph node, did some surgical intervention was also done, aspiration was done, or all things were treated with drugs?
No, sir. So aspirate was done for a diagnostic purpose,
Right.
for culture and expert.
It was very angry looking abscess like.
Right. But it responded very well with steroids and settled down.
Right. Very good. Very good. Thank you.
Discussion also. So can we have the introductory slide of Dr. Manoj K. Bhatnagar, please? Introductory slide.
Sir, please unshare screen, sir. Dr. Anuj.
Okay.
So Dr. Anuj K. Bhatnagar is a great friend of mine, and he's the academic director of the DNB courses. And he's a postgrad teacher of National Board of Examinations. And he's doing some phenomenal work in the TB research, especially drug-resistant tuberculosis. He has been a great friend of mine, and we know each other for about 30 years. And research work, especially in drug-resistant tuberculosis, is going to be, a revelation in future. So we are fortunate to have Dr. Anuj Bhatnagar in the panel today. So request Dr. Anuj, please.
Thank you, Dr. Manoj, and thanks a lot. In contrast to Dr. Bornali, my presentation is quite simple. I'll actually like to share some cases which I have faced in this institute while managing MDR TBA, and I've just got some one or two cases which I feel are very common and are commonly faced by every doctor, every pulmonologist, every TB specialist when he is managing MDR TB case. I'm just sharing 2 or 3 cases which cover quite a number of aspects of these 2 special scenarios in MDR TB. I've specially selected two cases with specific situations. Now, the first case is the case of MDR TB in pregnancy. I had a 30-year-old lady who presented to me with MDR TB. In fact, she had no past history of anti-TB treatment, and she was a close contact of a patient of MDR TB whose grandmother was taking the treatment. Now her she was a case of the left cervical lymph node, and the pus for CVNAT was done on 19th of April this year only, in which MTB was detected to be the load was medium and was found to be rifampicin resistance. Now the culture DST for AFB is still awaited in this patient, but the patient was 20 weeks pregnant. She was given the offer of medical termination of pregnancy. Since the age for medical termination of pregnancy has been increased to 24 weeks, and the patient but she refused, and she was willing to continue her pregnancy. So now the thing is, we went further. She was counseled regarding the need for regular checkups with the gynecologist, the requirement for more frequent blood investigations, that the treatment for MDR-TB in a patient is a challenge, and what to speak of a patient who is a pregnant lady, because it will challenge the outcomes, especially it is an extrapolatory case. We had to actually look for it is a rule that if you have a lymph node TB, look for every other site of the possible sites of a lymph nodes. Fortunately, there were none. It was only a single right supraclavicular necrotic lymph node. The size was quite significant, around 3.3 into 2 centimeters. Fortunately, no sites were involved. So this patient actually agreed that she would continue the regular treatment.
Now, there is some network issue from your
I'm
side.
sorry. There are network issues on my side. Now, what exactly is the management of this? Is how the national program recommends the management of MDR-TB patients during pregnancy. Now, if there is a patient who has, now this is 20 weeks, but now it has been changed to 24 weeks. Now, if she is up to 24 weeks, the patient is unwilling, then the treatment is given, the patient is advised for constant follow-up, and then depending upon whether the pregnancy is more than 32 weeks or less than 32 weeks, the regimen is decided. In addition to all the other factors of deciding whether a shorter MDR regimen is started or a longer MDR regimen is started. Now, if suppose the patient has crossed 32 weeks of gestation, the patient is a candidate for a shorter oral bedaquiline containing rifampicin resistance regimen. I'll tell you the reason later. Now, if suppose she's 32, the gestation period is less than 32 weeks, then the patient is a candidate for all or longer bedaquiline containing regimen. So why? Now, please remember that shorter MDR regimen cannot be given in a patient up to 32 weeks of pregnancy, because ethionomide is a mandatory constituent in shorter MDR regimen. Remember, there is a regimen that has been recommended by the WHO. The shorter all oral longer regimen has been modified with 2 months of linezolid instead of ethionomide. It has been approved by the National Technical Expert Group, but is yet to be recommended by the National TB Eradication Program. And ethionomide is not recommended before 32 weeks of pregnancy due to the potential teratogenicity in the first trimester and risk of hypothyroidism in the infant in the second trimester. So you have to design a longer all oral MDR regimen to basically you have to avoid the toxicities, and you have to take the special care to assess for anemia. There can be anemia due to nutrition, or it can be due to linezolid in these patients. Also assess for depression or psychological changes, pregnancy induced or cyclocerin induced, or a postpartum depression. It is mandatory that the patient is registered with a gynecologist or obstetrician, because this has been recommended in the program. Because every patient who is receiving bedaquiline based regimen and is pregnant, the outcome has to be strictly monitored and reported to the National Technical Expert Group. The reason being that the recommendation is conditional. The group of gynecologists who have finally approved this regimen for inclusion into the national guidelines, they made it as a condition that certain things need to be met, that the fetal health has to be monitored more regularly. The patient has to be strictly followed, and more regular follow-ups of investigations like TSH have to be done regularly. And even in an infant post-birth, the TSH might be required to be monitored. Now, in this particular patient, we got a fetal ultrasound done. Now, the recommendation is that you get a fetal ultrasound done at least 18 weeks of pregnancy if the patient is continuing the pregnancy, and 32 weeks of pregnancy to see for fetal growth. Intrauterine growth retardation was the only significant side effect that was found to be the effect of a bedaquiline-based regimen in a case of MDR-TB. So this patient was started on the usual medicines, but now this patient is awaiting her culture DST report. Now what will happen? This is a hypothetical situation now, because this might happen any day now, that when I go back and I might get this result. What will happen if this patient test resistant to quinolones and develops severe anemia or both? What happens now? Now, what is the next choice? What is the next replacement sequence? If the patient is resistant to quinolones, I cannot continue levofloxacin. You will have to replace it. What is the first replacement sequence? You cannot use geliminid because its safety is yet to be established in pregnancy. We cannot use amikacin in the first 32 weeks, at least only in the postpartum, not until the pregnancy is over, because it has the potential for 8 nerve damage. It can only be started in the postpartum period, but with the caveat that the patient must not be in the final 12 months of the course, because it cannot be started in the final 12 months of the course of treatment. Then once again, ethionomide cannot be used. So your first 3 drugs in this replacement sequence are gone. So my replacement options in a case of pregnancy with additional resistance are pyrazinamide, ethambutol, and PAS. So I just hope, since the index case was plain multi-drug resistant TB, I just hope that this patient doesn't test additional resistance. This is the real scenario, and that in fact I have faced 3 cases where the patient was pre-XCR and this patient ultimately had to go on to PAS. So this is the first case. Now so what are the issues? What are the additional monitorings required? You have to monitor the TSH quarterly. You have to get the infant checked for early evidence of hypothyroidism. The fetal abnormality scan at 18 weeks and ultrasound growth scan at 32 weeks, you have to get that done. And the fetal echo is only required if there is an abnormality on the ultrasound. If drug reactions are more common, you have to check for the safety, especially the anemia and TSH. There are more frequent ECGs required
Mishra.
and CBC.
No.
And mandatory ANC registration and follow-up by the obstetrician and gynecology. And mandatory delivery in a tertiary care institute in the presence of a pediatrician. And the patient must be counseled that during the period of lactation, the child has to be given formula feeds. Now, I'll present 2 patients with renal dysfunction. One patient will be a post-renal transplant patient. Now, in the first case, is a 58-year-old diabetic with disseminated TB of which was both pulmonary and extrapulmonary with abdominal foci. The patient was diagnosed with a case of MDR-TB on 19th of July 2022 in the sputum. The patient had a deranged renal function due to long-standing diabetes mellitus. The baseline pre-treatment evaluation had the pancytopenia, picture of pancytopenia. HP was 5.1, TLC was 4,000, and the platelet count was 95,000. The baseline creatinine clearance was 25.21 milliliter per minute. The remaining investigations were absolutely normal. Now, what are the potential challenges this patient I faces in this particular patient? Now, in this particular patient, since the patient is a case of chronic kidney disease, there might be a case of you can have episodes of anemia, and there is a repeated need of getting the CBC done. You can have a dyselectrolytemia in a case of CKD before or during the course of treatment. The patient will obviously go into a dialysis as and when it is decided by the nephrologist. the patient will require strict diabetic control. The patient has more chances of adverse drug reactions, and any challenges of additional drug resistance and drug interactions had to be dealt with. Now, this is the replacement, the dose adjustment of anti-TB drugs in the presence of renal impairment. Now, this is recommended dose and frequency for patients with creatinine clearance of less than 30 ml per minute. And you can see which particular drugs are requiring a dose adjustment or an interval adjustment. Now, particularly, there are some important drugs where you don't have to adjust the dose or the frequency, like for example, bedaquiline, like for example, moxifloxacin, ethionamide, linezolid, and clofazimine. So we had a backbone that for at least 4 drugs of the 5, you did not require any dose adjustment, and this is what was done. Now, in this particular patient, the patient was transfused whole blood, 2 units were given. The patient was started an all or longer regimen without linezolid in view of the baseline pancytopenia. The final regimen for the patient was bedaquiline, delamanid, moxifloxacin, clofazimine, and cycloserine was started at 250 milligram per day as is recommended. The patient was referred to a urologist and was advised dialysis. Strict ECG and electrolyte monitoring and KFT monitoring throughout the treatment was recommended, initially monthly for the at least first quarter or as required. Now, my problem started later. This patient was detected to be resistant to quinolones and pyrazinamide and cultured ESG. Now, for me, 2 drugs in the replacement schedules were gone. Moxifloxacin had to be stopped. Now, in this particular patient, I had to give a challenge of linezolid. Since it was not used, I decided to give linezolid in this particular patient. The patient developed more than 10% reduction in hemoglobin and platelets. We decided to discontinue that, and finally, this patient was continued on ethionamide, and ultimately the patient got cured. The next patient is somewhat similar. He is also a case of chronic kidney disease, 65-year-old male, but this patient actually had presented to us. He was MDR TB, but this patient had already had a renal transplant, somewhat similar to Dr. Bornali, but something different. Now, this patient presented with disseminated TB. Quite a number of cases that I am getting now ever since 2020. Almost 75% patients are having disseminated TB if we look for the sites. Now, pulmonary plus extrapulmonary TB with just one abscess. There was a history of ATT intake multiple times. 2018, he had taken drug-sensitive TB regimen for 6 months from private, whose outcome was treatment completed. In 2019, the patient had another 12 months of treatment, but defaulted the treatment, but there was no documentary evidence with me. The first CBNAT, which was done in December, here was also resistant to INH and quinolone. The patient was sensitive to second-line injectable. And the cultured EST showed a quinolone resistance and a pyrazinamide resistance. Now, this patient was on immunomodifiers, everolimus, lantus, actrapid, and visalon. Now, the creatinine clearance in this particular patient with a single kidney was normal, 103 ml per minute, and all other baseline pre-treatment evaluations were normal. So, what is the problem in this patient? As Dr. Bornali had also discussed, these are the drugs actually which are basically used in renal transplant, prednisolone, now tacrolimus, everolimus. Now, the problem with these drugs in an MDR regimen is that they are basically mediated. They actually are metabolized through the CYP3A4 pathway, similar to bedaquiline and delamanid. Now, they can have the effects of the metabolism of bedaquiline and delamanid, and there is a major risk of irregular heart rhythm, and regular ECG monitoring is recommended. This is something which is most important in this particular patient in an MDR regimen. Cyclosporin was another option that could have been changed. We actually took an opinion with the nephrologist that which particular medicine could they modify the immunomodifiers. They refused. they had the major risk of hepatotoxicity. And so using concomitantly with linezolid or with bedaquiline actually had great risk of running hepatotoxicity. So in this particular patient, what we did was for the issues that we had were basically the strict diabetic control. Now adequate, we had to protect the single kidney, and we had to monitor and manage the ADRs. Now, my problems were potential QT prolongation with everolimus and bedaquiline / delaminate, potential hepatotoxicity with cyclosporine, azathioprine anti-TB treatment, and the potential renal toxicity with second-line injectables. So, second-line injectables are gone for me, and bone marrow suppression with linezolid. So, finally, this patient was given the treatment of bedaquiline, linezolid, clofazimine, ethionamide, and cycloserine. And for all these above reasons, with regular ECG and LFT and CBC and electrolyte monitoring, and the patient is continuing treatment, and the patient is now microbiologically negative. So this is all these things. Basically, these are some cases, some challenges which you will face while you are treating such cases. You will actually get all these cases, variety of such cases with increasing frequency. And these are some of the pointers that I use in my patients to manage these cases. And I'm still continuing to manage these cases. The patients that I have shown, only one patient has finished his treatment. The remaining two are still under my care. So I cannot show you the outcomes. Thank you. Thanks a lot.
Thank you, Dr. Anuj, for discussing difficult cases of FDR-TB in pregnant lady and cases of renal dysfunction. These cases were really challenging and quite informative. So we'll be discussing some of the points, which Dr. Bornali mentioned and Dr. Anuj, both you also mentioned during our panel discussion. So we would request the Nitin organizers to please share the slides of the expert panelists before we can move on. First up, Dr. Ajit Prasad. Nitin. So Professor Rajendra Prasad doesn't need any introduction. He's teacher of the teachers. He has been director of Vallabhbhai Patel Chess Institute, then Safaib Medical Institute. He has been professor at KG's Medical University, Lucknow for many, many years. And many of his students are, doing a wonderful work in pulmonary medicine and tuberculosis. He has been actively involved in the WHO and National Tuberculosis Program. Is still a very active person and quite fit, and is an inspiration to all of also recipient of Dr. B.C. Roy National Award, and I am very glad to inform you that I have been his student. So I always look forward to his advice and guidance in every sphere of life. So the next panel, the next panelist is Dr. Sameer Bansal. Can we have his slide, please? So Dr. Sameer Bansal is consultant pulmonary critical interventional pulmonology, Apollo Hospitals, Bangalore. And he's currently the clinical head at Vayu and Apollo Hospital for more than 10 years. Active involved in various research and innovations. Trained in Mumbai from the prestigious JJ Hospital, Grand Medical College. Has been an avid researcher and well published. Has a lot of book chapters. And he's one of the COVID warriors by Max Life Foundation in 2022. So his list is quite wide, and I really welcome you, Dr. Sameer Bansal, to be on board today. May I have the slide of Dr. Gyanshankar, please? So Dr. Gyanshankar is the Mishra. Dr. Gyanshankar Mishra is the Associate Professor, Respiratory Medicine, Indira Gandhi Government Medical College, Nagpur. He's got a teaching experience of more than 14 years. His areas of interest are TB diagnosis and management, drug-resistant TB, TDM, ADRs, and PFT. And he's got a number of notable achievements, including the terms coined as Bindi tuberculosis by reporting the first such case in medical literature. And his featured comments in tuberculosis in esteemed journals as Lancet, NEJM, Nature, and IJTLD. Has published the largest study on daily fixed dose combination based anti-TB related ADRs under programmatic conditions in India. So I welcome you, Dr. Gyanshankar. You are an avid researcher and well published, well recognized. So thank you very much to be on board today.
Thank you.
So once again, I welcome all the esteemed experts on board, and maybe we can go ahead with
Dr. Manoj, I just need to, I have the privilege of introducing yourself. Nitin, can I have Dr. Manoj Goel's slide up, please? Again, Dr. Manoj Goel doesn't really need any introduction. He's one of the stalwarts of pulmonary medicine in India. And he's a great colleague, and we all work in the same area, and I know him so well. And he's got a tremendous drive in academics, in research, in organization of the regular meetings, and the Haryana chapter of ICS that he has taken on. He's, of course, the principal director and head of pulmonary critical care sleep medicine in Fortis Memorial Research Institute of Gurugram, and has published a book, Bronchoscopy in ICU, a very valuable addition to our the sort of all the books that we read on respiratory medicine, as well as he does an annual course on bronchoscopy. He's the expert committee member for Indian guidelines on bronchoscopy, EBUS, medical thorax, sleep, and has received oration awards, has done oration awards, and many publications in top journals like Lancet and NEJM. With that, I think he's an expert at moderating our sessions, and that tells us about his wide base of knowledge on all these subjects. Over to you, Dr. Goel.
Thank you very much, Dr. Bornali. So we can move ahead with the panel discussion. So my first question would go to Dr. Rajendra Prasad, sir, and this is a question which a student would ask his professor. So I'm asking you a very straightforward, simple question, sir. What is extrapulmonary tuberculosis, and why extrapulmonary tuberculosis is altogether a different entity?
Thank you, Manoj. First, let me thank at the beginning for including me in a panel discussion. I'm seeing this pulmonary medicine for last 50 years, more than 50 years, and I'm very happy that we have students like Manoj Goel, and literally I have taught somebody directly and many of you indirectly. So that's a good news. And what we have dreamed in 70s and 80s, actually everything is coming true now. Pulmonary medicine, the shape of pulmonary and medicine and interventional pulmonology has gone to the extent what we dreamt in 80s and early 80s and 90s. And now I'm happy that our second generation and third generation has come, and they are doing very well. So compliment to all of you. Manoj, what a question you put to me is how to manage the somebody who is receiving anti-TB drugs and develops the hepatotoxicity.
No, sir, my question is, what is extrapulmonary tuberculosis? And
sorry, extrapulmonary. The extrapulmonary tuberculosis, most common form of tuberculosis is pulmonary. What is about 75 to 80%. And about 20 to 25%, they are extrapulmonary. And commonest, extrapulmonary TB means anything except lung. They all come into, but the common extrapulmonary tuberculosis are like lymph node tuberculosis, as some of the cases Bornali has shown. And then we have pleural effusion, one of the another. And then we have tuberculous meningitis is one of the common extrapulmonary. Then bone and joints, genitourinary, skin, any organ can be involved. Then it will be known as extrapulmonary tuberculosis. Now, if I want to say that what is the basic difference between pulmonary and extrapulmonary? The one thing is that the extrapulmonary tuberculosis is usually a passive bacillary disease. That one thing you have to understand. And the second thing, because of the difficult areas sometimes like bone and joint, genitourinary, it's very difficult to get the specimen. So we face a lot of diagnostic issues, and many times the diagnosis is basically clinically diagnosed, because today we have two types of diagnosis, microbiologically proven. So very few numbers, few percentage of the extrapulmonary tuberculosis, we are able to prove them bacteriologically, a microbacteria. Second thing, as far as, so that this was the diagnostic dilemma. And then about the treatment of extrapulmonary tuberculosis, of course, essentially now we have no guideline, which was developed way back in 2014, and now it has been released in 2023. And essentially the treatment remained the same for pulmonary and extrapulmonary. Only one or two exceptions, that sometimes in extrapulmonary sites, especially TBM, bone and joint, you have to prolong the treatment. Apart from 6 months, probably you have to go for another 3 to 6 months. So treatment can be prolonged up to 9 months, 1 year, sometimes. That is another issue. And then as far as the monitoring of disease is concerned, that is again a problem. That is why many of the extrapulmonary sites, they are treated very over. I have seen cases of bone and joint tuberculosis. Orthopedic surgeons are treating for 2 years, 3 years, 4 years. So that is because we don't have a very end point that when to stop. But what we advise that is another issue sometimes we face in extrapulmonary. And then in extrapulmonary TB is another issue that some of the extrapulmonary sites, you must remember that they require steroids in their management, especially if I'm talking of pericardial effusion and the tuberculous meningitis. There, I think the steroids is quite absolutely indicated. I think, Manoj, these are the few areas which I wanted to say that how extrapulmonary TB is different than the pulmonary.
Thank you, sir, for defining extrapulmonary tuberculosis briefly, in a very lucid way, and also telling us how it is different from pulmonary tuberculosis. But one point which I think is important to stress here is that if somebody has got a pulmonary tuberculosis along with extrapulmonary tuberculosis, then this patient would be labeled as a pulmonary tuberculosis.
Yes, definitely.
So, Dr. Samir, there's a lot of talk about tuberculin skin test and IGRA, and ours is tuberculous, endemic country, and majority of us, after the certain age, maybe years, more than 50% of the people would be, sensitive to tuberculosis, and these tests would be positive. So, what do you think is the role of tuberculin skin test and IGRA in the diagnosis of extrapulmonary tuberculosis? Or knowing very well, these tests could be even the present patient who is asymptomatic without having any kind of tuberculosis. Would you still recommend, these tests where you're suspecting extrapulmonary tuberculosis? Dr. Samir, your opinion, please.
Sure. Now, first of all, thank you, Dr. Manoj, for that kind introduction, and Dr. Bornali and Dr. Anuj for lovely talks. So I think one of the things, I think my job is also made easier by Dr. Rajendra Prasad's earlier question, why do you want to really put extrapulmonary tuberculosis as a different entity? And that's because, these are possibacillary. And as Sir very well highlighted, there are certain instances wherein you cannot really get a specimen, say joint tuberculosis, joint or bone involvement. I think that is where these tests come into play. Now, of course, there are certain limitations, as you rightly pointed out, in our setting, especially, whether in high tuberculosis burden countries. In fact, there was a lovely paper by Dr. S.K. Sharma, sir, back in 2017, in which they showed. But again, most of these studies are for diagnosis or, for latent tuberculosis infection. Now, when we talk about the role in extrapulmonary TB, yes, whenever you cannot get a sample, for microbiological diagnosis, when the clinical suspicion index is pretty high, therein these particular tests can come as an adjunctive test, which can help in guiding the treatment. Or rather, when you have a very strong clinical suspicion, you cannot really get a sample, or even if you got a sample, but because of possible bacillary nature, these tests may be negative. So certain tests come into picture, such as, say, histopathology, whenever you have it, or maybe, when you have these sort of tests. IGRA, which may be IGRA, which may be positive, or a tuberculin skin test, which may be highly positive. Now, accordingly, the cutoffs, they keep varying, because if you have had a BCG vaccination, maybe more than 15 mm or so. So again, not solely diagnostic, but do have an adjunctive role in case of extrapulmonary TB.
Yes, Dr. Saveer, I agree with you, and they do not have a very high degree of role in diagnosing extrapulmonary tuberculosis, neither in ruling in or ruling out. But one scenario when you have suspecting sarcoidosis is a strong differential, then
Yes.
skin test especially would be very helpful. If it is positive, you would favor more in you would go in favor of tuberculosis more as compared to sarcoidosis. So possibly that is one area, one place where these tests could be very useful. Now, Dr. Gyanshankar, the expert MTB or the NAT test have been the breakthrough inventions in the recent past, and they actually changed the management of the tuberculosis in terms of early diagnosis, especially the pulmonary tuberculosis. But in EPTB, the scenario may be a little different. So what makes use of expert MTB RIFA in EPTB different? And what is the diagnostic yield of NAT and gene expert ultra diagnosing extrapulmonary tuberculosis? Dr. Gyanshankar, please.
Thank you, first of all, for inviting me to this CME. I thank the organization ICS. In extrapulmonary TB, the important point is that these are paucibacillary lesions, unlike the pulmonary TB ones. And these are precious samples. Basically, it is very difficult sometimes to get a second resampling done. So the diagnostic test has to be accurate. So expert MTB does two things. It lets us know the presence or absence of TB bacilli and the presence or absence of RIF resistance. Now coming to the diagnostic yield of NAT and gene expert, there was a very good Cochrane review published in 2021, which has compared the NAT ultra and the NAT vis-a-vis in the different extrapulmonary samples. So basically for CSF and pleural fluid, it has a higher sensitivity, ultra, as compared to NAT. And for lymph node, the NAT seems to have a good sensitivity. If the values are to be seen, then for expert ultra, the sensitivity for CSF is somewhere around 90% compared to expert, that is 71%. For pleural fluid, ultra is 75 and the normal CB NAT is 50. Again, for spinal TB, ultra has been shown to be a very good test as compared to NAT. This was in a December 23 publication. They had shown when compared with a composite reference with culture and histopath. So for all these lesions, you can use ultra and CB-NAT. Basically for CSF, pleural fluid, ultra has to be preferred, and for lymph node, the CB-NAT has to be preferred. For spinal lesions in CT carotid biopsy and open biopsy, ultra is to be preferred. These are the different yield for samples. The WHO recommendation also gives the same things.
Thank you, Dr. Gyanshankar. So basically, these tests also have a lot of value in diagnosing extrapulmonary tuberculosis, especially ruling in tuberculosis. But if these tests are negative, it does not rule out the possible tuberculosis. That is something which is important to understand. And as far as I remember, WHO does not recommend the gene expert test in pleural effusion. But we do these tests because to rule in, because if it is positive, then we know we are treating with a tuberculous pleural effusions. So thank you, Dr. Gyanshankar. Now, next question goes to Dr. Bornali.
Manoj, may I come in?
Yes, sir, please.
I agree with you that in pleural effusion, the role of gene expert and these tests are very rare. But what I have seen in my day-to-day clinical practice, many times there are a false diagnosis of even MDR and given in these cases. Because I have seen that in my own day-to-day clinical practice, sometimes we see that these reports are maybe not from good lab, maybe a lot of quality control issues. These reports are fallacious. So one has to be, if you are doing unnecessary test, and if you are getting sometimes a false report, then it creates a problem and patient goes into a lot of issues. So those things should have been always before you send for any. Because what you said, Manoj, is very right. Every pleural effusion is being aspirated, is being sent for these tests. So, and the sensitivity and specificity has been worked out to be not very high. So those things must be kept in mind.
Thank you, sir. I think the quality control of the test is very important, and
very important.
Every test has to be taken in consideration in the clinical context only. So thank you for very much, sir, for bringing out this very important point. Yes. So the next question goes to Dr. Bornali, and now we talked about the value of the expert MTB and NAT test. So we are suspecting patient may be having a resistant tuberculosis, and then what do you think is the role of the line probe assay, the next generation molecular test in extrapulmonary tuberculosis?
Yeah. Yeah, that's a great question, Dr. Goel, because line probe assay in when smear or culture are positive in pulmonary TB, that is the standard of care. And and manufacture validates its use only in pulmonary specimens. WHO module for diagnosis 2021 also only refers to LPA use in sputum, and it says that for extra pulmonary samples it has not been adequately evaluated for use by line probe assay yet. Now, in our own diagnostic algorithm, the integrated diagnostic and treatment algorithm by in our national program, of course, after NAT is upfront, and after that, it is line probe assay. And that is something that we follow, because that is the way we have to do it. So coming to extrapulmonary samples, therefore, technically, if they are positive in, if they are positive in either in the same way in culture, liquid culture, or in smear, then I think it is a reasonable thing to use it, because this is the only way we get to know drug resistance or drug sensitivity, because XDR, which is the other option we have, is really not part of our algorithm yet, not nationally utilized, and it's not present in most government centers at the moment. So all we have in some ways is line probe assay. And while there are, obviously it's not a clear-cut guidance to use it, but I think in our clinical practice, to get a very quick drug resistance, a DST, as early as possible, rather than wait 6 to 8 weeks for the culture, then I think definitely this is what, as clinicians, we would aim to do, even though there is no, there is not complete clarity from WHO, etc., on this. I mean, that would be my kind of view on this.
Guidelines do, recommend the line probe assays in extrapulmonary specimens, especially in lymph node tuberculosis. Dr. Rajendra Prasad, sir?
Well, guideline is basically for, extrapulmonary side, they are silent, actually, I must say. But the pulmonary sides, they are very clear. But for extrapulmonary, but as a rule, if somebody is suspecting drug resistance and want to diagnose quickly, and especially what Bornali said, if you can get some positive samples, then it is better to do for line probe assays, to have an early result, because line probe assays, it takes about 2 to 5 days maximum to give you the results about the drug resistance. So that is how, although extra pulmonary tuberculosis, in NTEP, there's hardly very little, not very good, guidelines are available. I think Anuj can talk much better in this. Anuj, you can come in.
Sir, yes, sir. The guidelines are absolutely there. The guidelines are there, and phase-wise training is about to commence. There is a specific guideline for management of extrapulmonary TB, and that involves doing every molecular test at the start, if possible, if required, then on culture. Otherwise, if it is a direct smear is positive, at least trying to go for an LPA straight away, apart from the NAT. So that is already there, and there are specific guidelines now for every extrapulmonary site.
Actually, this extrapulmonary guideline was developed in 2014. Luckily, I was part of that guideline.
But it has been
all the evidence based, and in those guidelines, they have advised the role of this molecular test.
The fresh guideline is the fresh guideline of 2023 is there, and that can be easily accessed from the.
Yes, the same guideline has been now
been modified completely, and for chapter wise.
Right. So, as far as my lab is concerned, they're not doing line probe assays in extrapulmonary specimens. I don't know about Dr. Bornali. Your lab is doing it?
No, they're not. They're not. They're doing XDR, but expert XDR, but not line probe assay.
See, Dr. Manoj, we are doing expert XDR for if suppose we are able to obtain an adequate sample. But for obviously precious samples,
It's still in the program. I think the expert XDR is still being.
Sir, it is yet to be approved, but
Yet to be approved. Yes.
we are actually using it because we have the 10 color cartridge system.
But I believe also that's a good test. It can give additional information about the drug resistance very quickly.
Dr. Anuj, could you please adjust your audio? Maybe you can remove your this and talk directly with the computer. If it is possible, let's see how it goes. But anyways, the next question goes to Dr. Anuj, and we are talking about extrapulmonary tuberculosis, which is possibly and the drug sensitivity is really possible because the cultures are not grown. So now there is a possibility that this patient could be having drug-resistant tuberculosis. So when would you consider, the drug-resistant tuberculosis, the culture is not positive in extrapulmonary tuberculosis? Dr. Anuj? I think we have lost contact with him. Maybe Dr. Rajendra Prasad, sir?
Anuj has come. You repeat the question?
Yeah. So I'm talking about the role of how would you diagnose drug-resistant tuberculosis, especially extrapulmonary tuberculosis, if the cultures are not available?
Well, if suppose now this is something which is a challenging thing. It's a day-to-day thing given. Once again, in a government step, I am not able to do therapeutic drug monitoring for every patient. Now that is something which is a caveat. But if suppose the patient is taking the medicine as is recommended by the standard TB guidelines, the patient is giving the adequate dose, the compliance is fine, despite that the patient is worsening. I have ruled out the paradoxical reaction, but still the patient is worsening, new sites are appearing, the disease process is worsening, then I'll have to at some particular point of time put the case before my DRTB committee to take a decision on the clinical basis. Whether this patient will require the decision of MDR regimen. Quite a number of approximately in around 5 to 10% of cases, especially CNS TB, quite a number of them, you will have to require change of regimen in these patients. Now you suddenly find patients, even after 1.5 years of drug-sensitive regimen, they are getting fresh tuberculomas and lesions in the spine as well as in the different areas or different parts of the brain. These are the patients who actually frequently go for modification of regimen to an MDR regimen. There, it's better you take the decision in the interest of the patient. And at least in my center, we don't have any hesitation.
Right. Thank you, Dr. I know it's a very difficult question to answer, and decision is likely to be clinical only, and we'll have to depend on a very huge luck, to diagnose this patient and treat this patient. So very well answered.
Unfortunately, Dr. Manoj,
I totally agree with Anuj that as a clinician, many times we have to do this. Because if you see that patient is deteriorating and you have excluded other possible things, then only things come in mind is a drug resistance. And if it is not, we have been able to prove, even on presumptive ground, many times we do prescribe the second line drugs or drug resistant TB. And once even program even says that although program is that if somebody doctor has his guts to prescribe these drugs, I think program is not going to refuse straightforward. Even somebody has written as saying, suppose somebody has Cox abdomen and is suspecting some drug resistance, he is not able to prove it. Then and if he advises for, I think program is very open that yes, they can go for these regimens.
Thank you, sir, and thank you for the
program never says no, sir. The program never says no. In fact, ultimately, the decision has to be that of the committee. And once the committee decides, you can go ahead.
Go ahead.
What do you think is this committee all about? I mean, how do you, what is the composition of this committee, Dr. Anuj?
Sir, it's a standard DR. It's given in the National TB Eradication Program PMDD guidelines that you basically have the chest specialists, you basically have a microbiologist, you basically have the medical specialists, the relevant specialist of the particular field, like for example, a neurologist, like for example, a gastroenterologist. Now you basically discuss the case, put up in front of this multidisciplinary committee. It's something like your multidisciplinary discussion. Put forward the entire thing and then discuss about the patient's progress, the course, and take the final decision.
Totally
This
agree.
is actually a mandatory part of every DRTB committee.
Yes, so that's a very important point, and we must have those who are dealing with drug-resistant tuberculosis. They must have, this committee as per the national guidelines. That's a very important aspect we need to understand. So I come to Dr. Samir about the pleural effusion, which is a very common extrapulmonary tuberculosis. ADA is a very important biomarker in pleural fluid. So what do you think is the role of pleural fluid ADA, Dr. Samir?
So again, sir, as we spoke about it earlier, in especially these extrapulmonary tuberculosis. Now, all these tests, they are not very specific tests. Yes, of course, the sensitivity is on the higher side. So they are not the whole and soul, because yes, in our practice, we do come across a lot of cases. Patients started empirically on ETT just because the ADA was high. And, because the patient is not responding, so many times they refer to us for a fluoroscopy, for fluoroscopic biopsy. And many a times we have seen that, it ultimately turns out to be either some other bacterial lymphoma, or it can turn out to be, say, malignancies also for that matter. So yes, the sensitivity of ADA is pretty high, and that is why, the specificity is not that great. And so again, it has to be used as an adjunctive test. Say, for example, in a case of pleural effusion, I go ahead and obtain a sample. We do not really get any microbiological test positive or any molecular test positive. You have the tuberculin skin test, you have the ADA, you have, say, other parameters such as a lymphocytic predominant effusion on the cell count, on the differential count, along with elevated ADA. Then yes, in a clinical suspicion, in these cases, it can provide to some extent, yes, it can validate your clinical suspicion that yes, this may be a case of tuberculosis. But ultimately, it is not the whole and soul. And if at all you can get a tissue, if at all you can get that fluid for any microbiological evidence, you should really go for it. And if not, yes, culture does take time, but please make sure to follow those cultures, because ultimately, yes, the culture has quite significant sensitivity and specificity also. Even if your earlier microbiological tests are negative, you should really follow up on those. So ADA, again, just to summarize the whole thing, good as an adjunctive test, high sensitivity, but not very specific though. So always to be used in conjunction with your clinical suspicion and other tests.
Thank you, Dr. Sabir. Dr. Gyanshankar, would you like to add something to this? Dr. Gyanshankar?
Yes. So the new ICMR TB, the ICMR have come up with a TB standard workflow. So they have given the algorithm. So in that algorithm, they have mentioned that once it is exudative lymphocyte-rich pleural effusion, and there you have done the ADA, and if ADA is less than 40, so their pleural biopsy is indicated. If it is between 40 to 70, in these cases, AKT can be initiated, and if after 1 month the response is not there, then again go back and get a pleural biopsy done. Again, so in these two scenarios, pleural biopsy is indicated based on ADA.
Yes. So especially,
I think Manoj, may I come in?
yes, please.
These points are very well taken, but one thing I always say that suppose you are ADA, as Samir has said very rightly, it has got some adjunctive role. It cannot confirm the diagnosis of tuberculosis. But then another issue that I always say, if you are writing an anti-TB drug to a place, say in pleural effusion, even you have not been able to prove it and clinically you feel that yes, it could be tuberculosis. One thing I always say, you must exclude other conditions where you believe that diagnosis is something otherwise. Otherwise, giving anti-TB drug for 2, 3, 4, 5 months make the things worse. So what we have seen, so whenever we say that treatment is on the presumptive ground, one point we always say to our students, please exclude other common causes. If you are suppose it is pleural effusion, if you have slightest suspicion of malignant effusion or malignancy, you don't hesitate to exclude that. And if you have excluded, ADA is positive, you are suspecting, yes, you are all right to prescribe, and many of them they respond to this also. What I have seen in years.
So thank you, sir. The other problem with ADA is that we got different cutoffs in different labs. So that is something that we understand. But if I was going through the national guidelines, they have given an algorithm. So if the ADA level is equal to 70 or more, then you can initiate empirical anti-tubercular therapy. And if the ADA is less than 40, then you go ahead with pleural biopsy. Now 40 to 69 is a little gray area. In this case, if the age is less than 40 years, the patient got a fever, non-smoker, there is no alternative etiology, then you can initiate empirical anti-tubercular therapy for 4 weeks and see if the patient responds or not. If the patient doesn't respond, then go ahead with pleural biopsy. But if the age is more than 40 years, has been a smoker, then with 40 to 69, you must think of other etiologies, and these cases may be considered for pleural biopsy. So all these things have to be considered in the clinical context. So I think this was a very important point about ADA, because it's a very common test that we do in pleural fluid, and just getting ADA positive and starting ATT, especially if it's between 40 to 69, may be sometimes a difficult scenario. So Dr. Gyanshankar, my next question goes to you. So as far as the guidelines say that when you do a therapeutic aspiration tubercular pleural effusion, then patient is either having a large pleural effusion or is having breathlessness or is symptomatic in terms of dyspnea. So my question goes to you, what is a large pleural effusion? And if you have suppose a fusion of say 400 ml or 500 ml, the patient is not breathless, would you not do a therapeutic aspiration in this case? Because general tendency on one side is that one group believes that the pleural space should be made empty and free of fluid as much as possible. And whereas the guidelines suggest that you remove the fluid only if the patient has got a large effusion and he's got a breathlessness. What is your point, Dr. Gyanshankar?
Yeah, so you have correctly mentioned that the most of the times till many years the guidelines were silent on this, that when should a therapeutic tapping be done. So the ICMR guidelines, they have recently said that in moderate and large effusions, therapeutic tapping should be done, and also if the patient has breathlessness. Now large effusions typically mean that the hemithorax is opaque and the shift of mediastinum is there, or clinically is the whole of the hemithorax is involved. But normally what we do is, as far as possible, we do the dry tap, except in mild effusions, and then leave it. Because these tubercular pleural effusions, they have a high protein count and they have a tendency to get septated. So there is always a risk that septations will be there and fibrosis will be there, just based on normal physiology. So it is always better that if it is tappable, do a dry tap.
Dr. Bornali, what do? You go for a dry tap or you would leave some fluid? Dr. Bornali, madam?
Yeah, so I think I agree that, you want to take out the majority of the volume of fluid that is there and, leave minimum behind. We expect it to dry up, of course, with the medication, but we are all familiar with, how it becomes rapidly into a loculated, septated effusion if for some, not for every individual, but for some individuals, and then later needs, much more prolonged kind of or different kind of approach to get that space cleared. So I think I would tend to clear out as much as comes out freely and then let the rest dry up with the medication.
Yes, I think that is the most valid and practical point, and nobody likes to leave the fluid inside. And as Dr. Gyanshankar said, the fluid may get, cause more fibrosis in not only the pleural space, but also it can go into the lungs. And, these patients may over a period of time develop, chronic respiratory inefficiency. Of course, not proven, nowhere it is written, but we do find this thing, happening. Patients who have not gone through the adequate pleural aspiration coming out with these sequelae of tuberculosis with lifelong problems. So thank you, Dr. Gyanshankar, Dr. Bornali, for this insight. Now, Dr. Anuj, we switch topic a little bit and talk of NTM, another very challenging problem. And even the NTM may be positive.
Manoj, may I come for pleural effusion?
Yes, always.
Yes, it is always better that if you can aspirate to the maximum, But if your diagnosis is very clear, it is tubercular. What I have seen in last 50 years now I can say boost. Then majority of the pleural effusion, small effusions, they get absorbed once you aspirate it once. So I used to teach my students, if you are doing multiple time aspiration, you suspect about the diagnosis. Is it really tubercular? Is it not empyema? It's not a papillomatic effusion. So those issues, but usually it is a tubercular, ideally tubercular pleural effusion needs aspiration once. If it is moderate, more than moderate or massive, then definitely it requires, but one should always take care. We have seen some of the deaths in my in the re-expansion pulmonary edema is sometimes, if you do very rapidly, if you aspirate large amount of fluid and do it repeatedly, so these and another complication I have seen, the introducing the infection from outside. So, so those things must be said. And ideally, if it is a tubercular pleural effusion, my gut feeling is it hardly requires once. If it requires second time, it's rare. And if you give the adequate treatment, and especially in the moderate to massive effusion, if you initially you may use little bit of steroids. What I have seen, most of the pleural effusion, they subside, they hardly leave any scarring, any pleural thickening. But yes, in some cases, I do agree, this all happen. Post-tubercular lesions are there.
Thank you, sir. So moving on to Dr. Anuj, please. So how do you diagnose NTM?
That's very difficult area.
Dr. Anuj? Dr. Anuj?
Yeah. So basically, now you basically suspect non-tubercular mycobacteria in certain groups of population. I mean, those people who have old lesions in the lung, who have pre-existing abnormalities in the lung, who have reached a particular certain age group, or are having any immunodeficiencies. These are or having any particular use of certain drugs. So, I mean, all these predisposing factors are there, which predispose a patient to development of non-tubercular mycobacteria. Now, in such group of patients, if suppose you see the clinical picture that you have ruled out, you have basically a patient who has thin cavities on the chest X-ray. The sputum is positive, but the NAT is negative, and the patients these are the patients, I mean, in whom the first suspicion goes to non-tubercular mycobacteria. Your patient has the recommendations are very clear that there have to be radiological criteria, there have to be microbiological criteria. Please remember that you have to send at least 3 sputum samples taken at least 7 days apart for an AFB culture. Now, in at least 2 of them, if suppose sputum is sent, in suppose that in at least 2 of them, you have to ensure you have to get the non-tubercular mycobacteria of the same species, and in case of Mycobacterium abscescens, of the same subspecies. That is for sputum. Now suppose that you have done a bronchial aspirate, and the aspirate or the ball, it also grows non-tubercular mycobacteria. That one sample is sufficient. Or if suppose you have done you have a sputum examination, and you have also taken an aspirate, or you have taken a transbronchial lung biopsy, and the biopsy shows granulomatous lesions. Now, in these patients also, if suppose the sputum sample shows, a single sputum sample shows a non-tubercular mycobacteria, this patient is a case of non-tubercular mycobacteria infection.
So important, one culture or one sputum smear positive for NTM does not mean that patient
one sputum culture alone will never ever mean. You have to basically, it has been seen that in 90% of cases, if suppose you had not done, you were overdiagnosing it.
So we know that NTMs are the colonizers, and we can have.
They are the colonizers. They are very, very ubiquitous in the environment, and they will always be overdiagnosed if you only take one culture.
Very well said.
Manoj, the other name of NTM is environmental mycobacteria. So they are ubiquitous, as Anuj said very rightly. So probably one sample may not be sufficient to diagnose, that there will be overdiagnosis. And then when you diagnose over, there would be an over treatment. So
yes, that's those. Goes to you, Dr. Rajendra Prasad, sir. What is the role of NTM PCR?
Manoj, you put a very difficult question to me. And when I read your questions, and then I interacted with some of two of the microbiologists, leading microbiologists of the country. One was associated with me in KGMC, and another was associated with me in Patel Test. So, even some of the PCR test has come to detect the NTM. And but their sensitivity and specificity, although sensitivity is not very high, but specificity is very high. And when we are doing this test, one has not to forget that it cannot differentiate between live bacteria and dead bacteria. That is another issue with these tests. And then it can tell you which NTM, which species. And I think one of the tests is there with TrueNet machine, Malbio. They have one test, I think they have come with, it is chip-based test. So they have come with that can detect the NTM by that test. And another area which is coming up, I think, is what I have read, that genotype NTM DR means it can detect, it can differentiate several NTMs and their even resistance pattern, because the resistance pattern with the common drug is macrolide and aminoglycosides. So even some of the tests, what I have heard, is coming up with this, but it is not very routine, not used. It's somehow costly test, and then reliability is also not very high. So I would like to ask Anuj to add over it.
I think already it's 10, so we have to wrap up. That's it, and that's why I know the NTM PCR has not been included in the diagnostic criteria of NTM, and should not be done routinely unless you've got a very strong suspicion.
Yes.
Coming to my next question to Dr. Samir. Now, this is again very controversial. You've got disease diagnosed. Now, would you treat these cases?
So this is to cut a long story short.
Dr. Samir?
Yes, no, rightly said, sir. Again, a very gray zone. Because if we have to look at the guidelines also, I think the ATS guidelines which came, recently in 2020 also. So what is said is, yes, any patient who meets the diagnostic criteria for this NTM pulmonary disease. Now, of course, there's this clinical, radiological, and the microbiological. I think Dr. Anuj was going through that. So once you have this diagnostic criteria, what is suggested is that yes, you should initiate the therapy rather than waitful watching. Now, this is especially when you have a positive AFB sputum, or whatever sputum smear positive, or when your radiology, rather than say nodular opacities or any other signs, shows a cavitating lung feature. So again, this whole recommendation was a very conditional recommendation. It was again low certainty, and that is a very down below in the recommendation. They also gave this particular thing that yes, just because a patient meets diagnostic criteria does not necessarily mean that you should initiate the therapy also. So again, it's a very gray zone. So the idea is, yes, if a patient is immunocompromised, patient has significant symptoms, you have excluded all the other possibilities such as say tuberculosis and all. In this case, if the patient is meeting the criteria and you have significant cavitating lesions on the chest X-ray or a CT scan, yes, definitely you should go for it. And in some cases, you may, rather discuss with the patient that yes, what would be more appropriate if you are worried about, say, drug toxicity, or if the patient doesn't really want to take, or any of these situations, it can be a very shared decision also. So better is always to start, but sometimes in case-to-case basis, you may opt for watchful waiting also.
That's an excellent answer, Dr. Samir. I'm really very grateful to you for bringing out this clear-cut analysis of how to treat these patients. Thank you very much, Dr. Samir. Now, we come back to another clinical scenario, which is very common. It's about the lymph node tuberculosis. So Dr. Bornali has already touched upon that, and patient has got a lymph node tuberculosis, you start the anti-tubercular treatment, and then there's increase the size of the lymph node, or the patient develops a cold abscess during ATT. So Dr. Gyanshankar, what would be your strategy?
So after initiation of AKT, if the lymph node size increases or a cold abscess develops, so a good history taking will be required here. We need to check the proper treatment regime, whether the patient is receiving it or not. What is the drug compliance, whether the patient is taking it properly. Then regarding bioavailability, clinically we can see or check that whether the patient is taking drugs after a full lunch or dinner. This is most of the times in the field that they're not taking it after light breakfast as recommended. They take it after full lunch or dinner. So we can change that timing. Then we, yeah.
Applying the treatment, then I'm asking, what will you do?
Yeah. So after we need to rule out drug resistance, check the immune status, and we also need to rule out any secondary infection. So after all these things have been ruled out, this could be a possible paradoxical response to the anti-TB treatment. And as already it was explained in the slides that 20% of the patients, they do experience this. The management strategy is not well defined in the guidelines, but it could be range from observation. You can do an aspiration, surgical treatment, and a course of steroids could be done after ruling out all the factors.
Thank you, Dr. Gyanshankar. I think similar question goes to Dr. Bornali. Patient develops a new lymph node after 3 months of complete anti-tubercular treatment, or maybe at another site. What do you think is happening with the patient? Dr. Bornali, ma'am?
Unmute.
Any new lymph node, again, we have to aspirate it and send it for a smear, send it for experts, send it for culture. So that is a given. Now, lymph node TB is notorious for, for taking a very long time to settle or to have this waxing waning course. And I think, as Dr. Gyanshankar pointed out, very important to understand what happened in the last treatment. And, we have the options of doing therapeutic drug monitoring. In this, subsequently, if it comes positive again, the drug quality, compliance, drug interactions, comorbidities, we just need to have a sense of whether anything like that was there that had prevented a complete cure, and there was just a partial response, and then it came back. On the other hand, so I think first we have to make sure that, that the previous treatment had been effective and successful, or if not, then what were the reasons for that? And then we have to reevaluate with microbiology again. If it comes positive again, then we have to treat, bearing in mind all these things. So, I think that would be.
Yeah, thank you. So I think I'll ask Dr. Rajendra Prasad now and to pitch in here also. Now, would you do a gene expert when you aspirate these lymph nodes? And would you do a gene expert in these cases? Or do you think, would there be any value of gene expert positive in the lymph node aspirate in this situation?
Yes, in a difficult gene expert, if it is, now today we know that any patients of tuberculosis you are treating, your universal DST is must. So it is true for lymph node TB. If you can do it, ideally it should be done. Because you don't know that whether your person is a drug-sensitive TB or drug-resistant TB. So you can do a gene expert in such at least in such scenario where there is a paradoxical response, lymph node is waxing and waning. There, I think all sorts of investigation must be done to exclude any drug resistance. That is point number one.
My question would be different. So, the patient, and you've done a gene expert test, it is positive, there's no rifampicin resistance detected. Now, 3 months down the line, a patient got another lymph node, do a test, and again, the gene expert is positive, but rifampicin resistance is not detected. Would you think that patient is still having active tuberculosis going on?
Well, lymph node tuberculosis is one area which I think Bornali has already touched. About 30%. To my practice, I see more than 30%. There are a lot of issues of increasing size of lymph node, paradoxical responses, whatever you can say. But what I have experienced, that with the little prolongation of the treatment, many of the lymph nodes, they do respond. Of course, if it is just needs some surgical thing, we have to do that. Suppose there's an abscess, of course, you have to aspirate it, and sometimes you have to remove those lymph nodes. And the another area what I have experienced, Manoj, probably that in some of the lymph nodes which are very large, very caseating, caseating inside, you can see, if you get an ultrasound, you can see the consistency of the lymph node. Even some of the patients, what I have tried, I have written in my book also, that in such a scenario, a course of 6 to 8 of 8 weeks of steroids, but with adequate anti-tubercular coverage, many of the patients I have experienced, they have responded excellent.
So I think steroid could be a double-edged sword, and would be
I
a very
know that you have to exclude everything together. But in some of the scenario where you see that, suppose somebody has a mediastinal lymph node, it is quite caseating, quite large, and you cannot perform any other surgery there. A patient is not ready for anything. Then probably in such scenario, to my understanding, although it is not evidence-based, but we have used steroids, and the response has been excellent.
So, Dr. Anuj, I'd like.
If I may just, Dr. Goel. So I think for pulmonary TB, if you get, repeated gene expert, obviously the value is very limited because it'll keep coming positive and may not indicate active disease. But I think for extrapulmonary, if a new node has popped up and it is positive, I think you're obliged to still, treat it. While we understand that, there is so many, paradoxical reactions, so many other things are possible, but I think one still needs to, in the setting of extrapulmonary, I think the value of gene expert even a second time around is, I think it is there.
Thank you. I think we move on to next question to Dr. Anuj, and this is a very common referral that we get is of uveitis. The patient is symptomatic, doesn't have any features of tubercular toxemia, fever, weight loss, and doesn't have any respiratory complaint. Now this patient referred to us to differentiate whether patient got a tuberculosis or sarcoidosis. How would you approach these cases, Dr. Anuj?
Are you talking about ophthalmic tuberculosis?
Yes.
Tuberculosis?
Yeah.
Now this is a very common presentation. Now this is very common presentation in these in patients. Certainly, in fact, I have Dr. Manoj. Since you left, we have also have an ophthalmology department in my institute now. So this is a very common referral for us. A patient with the red eye, with the uveitis, since this is a granulomatous uveitis, and the patient will require anti-TB treatment. Now, in this particular patient, now let's talk about the diagnostic categories of ocular TB. Now, he might be a possible ocular TB case. He might be a clinically diagnosed ocular TB case for which he has been sent to me. Rarely a bacteriologically confirmed. If he is bacteriologically confirmed, he cannot be confirmed. He basically straight away put on treatment. But as we all know, that taking the sample is very, very difficult. Now, here comes the value of your MON2 test, or now what is shortly coming is CyTB test and IGRA. A question is put up regarding IGRA. Now here it adds a value. Now suppose there is a lesion which is difficult to differentiate between TB and sarcoidosis, a granulomatous uveitis. Like for example, quite a number of them. There might be anterior uveitis, there might be intermediate uveitis, there might be choroid tubercles. All these things, at least if suppose the patient is having this lesion, that you always go for a chest radiograph, you always go for a CT scan. My policy is to advise the patient regarding a CT scan of the chest and abdomen to see whether there is any other, and the patient's immunological test, either a MON2 test or an IGRA. If suppose the MON2 is positive, even if, or the patient has had a history of contact with the patient of TB, even if the CT scan does not reveal any other lesion anywhere else in the body, I tend to side ocular TB case and start the treatment.
Thank you.
On the other hand,
yes,
in quite a number of cases, I am able to find either the lungs or a silent lesion, most likely a lymph node, and then it is easier to treat. That yes, this is a clinically diagnosed ocular TB case. Very rarely, suppose it's outside, or if suppose the ophthalmologist is able to take a sample, then 1 or 2 cases I have seen the culture showing mycobacterium tuberculosis, where the diagnosis was confirmed. But this is a very common referral to me now from my ophthalmology.
Yes, this is. I agree with Anuj. Manoj, I agree with Anuj. When I was in KGMC, I think when you are doing MD, this is one of the common reference from Department of Ophthalmology. A young man, a young woman developed Eels disease, a loss of vision, diminution of vision, and you are suspecting to be uveitis, Eels disease, and so on. And what Anuj said, we did the same thing. First thing, we excluded tuberculosis in any other part of the body, one thing. And then we want to test was simply to our rescue. Somebody, suppose everything is excluded. We are not getting any lesion anywhere. And if want to test is positive and ophthalmologist is suspecting that it could be tuberculosis, then we always advise the anti-tuberculosis course for about 6 months. What the harm is going to get, because he is suffering from something which is very notorious. And what is my experience, what I have seen, that in many of such patients, they respond to treatment. The another point, Manoj, I wanted to raise here, I have seen all the extra pulmonary, all the means other than chest physicians, when they are treating extra, say ENT person, treating lymph node TB, bone and joint TB, orthopedic, Cox abdomen, they never advise the chest X-ray. We have, our teaching is, if person has an extra pulmonary tuberculosis, 25% of they may have some lesion into the chest. So that is to be. So my advice from this forum is that you are treating any sort of extra pulmonary TB, you are trying to diagnose, chest X-ray is mandatory to everyone to exclude any lesion.
Thank you, sir, for this.
That I see in the field, people do not advise chest X-ray.
Thank you, sir, for this important message. Now, coming back to Dr. Bornali, you already touched about the therapeutic monitoring. Just a revision from you. When would you advise therapeutic drug monitoring? Dr. Bornali.
So I think the main, yes. So I think the main thing is when the response to treatment has not been adequate, and one has ruled out drug resistance. I think that is the key thing, that we are certain that that the treatment given is correct. There is no modification required in the treatment, and I think, and the patient is not improving, then I think that is the time when one has to look at therapeutic drug monitoring. And typically, yes, patient comes back for follow-up without the improvement that one would expect on the correct regimen.
So, which drug you go for the therapeutic monitoring, and how frequently you do it, madam?
So we what we have now is rifampicin. I mean, of course, as you know, almost all drugs can be monitored for therapeutic drug monitoring. Hinduja, I think, has the facilities for everything. We have just rifampicin and isoniazid. And I think, you start monitoring, and once it reaches the therapeutic level with the correct dose, then you don't have to continue monitoring. But, you just have to keep titrating the dose with the with the level of the drug in the result of the TDM.
So after increasing the dose, after how much time would you do a therapeutic drug monitoring?
Well, we'd give it a week or so to repeat it again, and then by that time there's a steady state, and then we can assess if it has been effective, the dose.
The message is now therapeutic drug monitoring is available in India, and many centers are doing it. Medanta in Haryana is doing it. So it is available and it can easily be done. It's not very costly also. So coming to Dr. Samir again, what would be the absolute indications in corticosteroids in the management of tuberculosis?
Right. So I think, as I think Dr. Prasad sir also touched upon it. So majorly TB meningitis and TB pericarditis. These are the two major indications or absolute indications for using corticosteroids. And the whole reason is because, the whole immune response in these places can actually be very catastrophic. In one place, of course, associated with a lot of, focal nerve, focal deficits and all. In another place with constrictive pericarditis, and that is why it is important. However, there are other indications also. For example, the paradoxical response with iris kind of a response when you have ATT along with antiretroviral therapy. You may have TB vasculitis. We see that very commonly in our practice. Miliary tuberculosis, sometimes with bad hypoxia, again, a disseminated form of tuberculosis mimicking an interstitial lung disease kind of variety. TB rheumatism, Ponson's disease. So that also responds very well to steroids in that case, or even TB ophthalmitis. We were talking about TB uveitis and also. These are various indications. Yes, you do give steroids, but important thing over here again is what dose. Why? Because you have rifampicin, which is a strong enzyme inducer, and almost all the steroids that you give, the drug levels do fall because of rifampicin. And especially in cases of TB meningitis, when you may have anti-epileptics also, you would have rifampicin in case of drug-sensitive tuberculosis. So monitoring or rather, giving appropriate dose is something which becomes really important.
Thank you, Dr. Samir. That was very useful information.
Manoj, may I chip in for a moment?
Sir, quickly.
Role of steroid. I think Samir has dealt it beautifully. One of he was also your mentor, Professor V.K. Khanna. He taught us in 70s that one of the place for the absolute use of steroid is it's a life saving. Suppose somebody, you are diagnosed tuberculosis, he is in a pre-terminal or terminal stages of disease, then using some days of steroid to save his life first, because anti-TB drug will take time to act. So, and we have practiced this. When we see the patients of TB, they came into last stage and very terminal stages. So it buys some time. And many of the patients we have saved. That is the another area of when you can, the another area of use of steroids may be a severe drug intolerances, very severe, like the rashes and other things. There also we sometimes use steroid for a short duration of time. But whenever you use steroid, the rule says that your anti-TB coverage must be adequate.
Right, sir. So ARDS, tuberculosis ARDS, of course, is not very well studied. Is possibly another indication where the steroids would be indicated, as you said, is a life-saving drug. So anyways, I think they covered the steroids. So again, coming back to extrapulmonary tuberculosis, Dr. Anuj would require a very brief answer from you. After how much duration of anti-tubercular treatment should we assess response to treatment in extrapulmonary tuberculosis? Dr. Anuj? Dr. Anuj? Is he there, Dr. Anuj? Dr. Anuj, you have...
Sir has a network issue, I think, so maybe we can just move on to the next one.
Dr. Anuj? And can I have a video also? I think
he has some problem with his internet.
Okay. So maybe I can go to Dr. Gyanshankar to answer this question. When would you do the initial response workup in extrapulmonary tuberculosis? After how much duration? In pulmonary tuberculosis, we do it after 2 months and then maybe we de-escalate. But what about extrapulmonary tuberculosis?
So basically in extrapulmonary TB, we do it by clinical response because samples are most of the times not available. The duration of treatment, it depends on the site of TB. So the regime is fixed for most of the extrapulmonary TB, that the intensive phase will be of 2 to 3 months and followed by contrition phase. So for, let's say for TB spine, the total duration after 6 months will evaluate and again increase the duration. So from up till 12 months is recommended by the new ICMR guidelines. For CNS TB, 2 plus 7, 9 months of treatment is recommended currently. For abdominal TB, again, at the end of 6 months, you need to reassess. And for lymph nodes TB also at the end of 6 months, they say. And if the clinical response is not adequate, then you can extend the condition phase.
So actually, when would you start suspecting that the patient is a non-responder?
Non-responder after 4 months, basically.
Right. Thank you. I think that's the standard guidance. Coming to Dr. Ajay Prasad, sir, one great problem is the ATT-induced hepatitis. How do you manage, sir?
Thank you, Manoj. I think we are coming at the end of our session, I believe. So, this is, as you said very rightly, In our day-to-day clinical practice, we commonly see this problem. And ideally, when I say that somebody has come with some problem with hepatotoxicity, so what we actually say that we get, if the enzyme levels are raised less than 5 times, serum bilirubin is normal, he has hardly any symptom, only there you have detected by doing routine tests, that probably you have to do nothing, probably you have to continue the NTT.
That is fine.
And watch very carefully. Repeat LFT for 2 weeks, and if he develops in the meantime clinical symptoms, then you have to take action. What action you have? Suppose somebody has enzymes more than 5 times 1. He has serum bilirubin more than 2 times. That is second, and or else he has a symptom. Means common problem we see is loss of appetite, nausea, vomiting. That what usually we do is that we stop the anti-TB drug if the disease is not very lethal one for about 7 to 10 days. Wait for these enzymes come to be normal. Symptomatically, he improves very well. Then you have to reintroduce the drug. And reintroduction of the drug, there are two school of thoughts. One is ATS group, and ATS say that probably rifampicin has to be introduced first, and then INH, and then pyrazinamide, if you are treating the new case. And but the BTS thinker, they believe that it is after the patient has become okay and enzymes have become normal, then you introduce INH first, then rifampicin, and followed by pyrazinamide if he is tolerating. So whatever stage he is tolerating, you have to find out what drug may be culprit. And many times we have seen that they re-tolerate these drugs. The another issue with and suppose in scenario where he is not tolerating rifampicin and pyrazinamide anyway, then probably you have to add one or more drug which are hepatic safe. And then one has to keep in another point, I always keep in mind that when you are not using where you are not able to use rifampicin and main drug, then probably your duration of treatment has to be prolonged. It is not a shorter regimen. So these are the points we usually see that especially when we see that hepatotoxicity in a new cases of tuberculosis.
Yes, sir. Thank you. So about the INH, it is supposed to be the most hepatotoxic drug, but we don't see this happening in Indian population, as a matter of fact. And
actually, this is Manoj written in the Western book.
Yes.
What we have seen in India, I have hardly in my 50, I have treated more than 5-10 lakhs of patients. I have seen only 3 cases of isoniazid hepatitis, proven cases. So INH probably in our country is a very well tolerated. That is my, you can use my experience in this.
Yes, sir. So whenever we have a problem and the patient has got hepatitis, we would continue with INH and ethambutol, and then gradually introduce other drugs as the hepatitis improves. So again, clarify from you, it is 5 times rise in the enzymes, so it is more than 3 times rise in the enzymes.
What recent guidelines they are saying less than 5 times and more than 5 times. Okay. Initially, it was 3 times.
Yes.
Now they have come to the 5 times.
But our Indian population does not tolerate, the enzymes rising more than 3 times, and they would become symptomatic majority of the time.
That you have, of course, I said, if he's symptomatic, whatever is the level of enzymes, probably you have to act.
Correct. Right? So my next question goes to Dr. Bornali, and this is again a very important side effect which we observe is the peripheral neuropathy. So what are the drugs which can cause peripheral neuropathy? And many times, patients have joint pain, muscle pain, stiff joints. This is all developing during anti-tubercular treatment. So what are the culpable drugs and how do you treat this situation? Dr. Bornali, ma'am?
Please unmute Bornali. You are muted, yes.
Yes. So I think the first line drug that we are all familiar with that causes peripheral neuropathy is isoniazid. And this is because it decreases the pyridoxine levels, which is one of the neurotransmitters. And peripheral neuropathy presents as a glove and stocking, as we know. And for the first line, this is the most common, and we try to prevent it by giving pyridoxine alongside isoniazid treatment. Of the second line drugs, which we use for DRTB, linezolid is one of the big culprits, cycloserine, ethionamide. All of these can cause peripheral neuropathy. So the way to do it is, one is preventing by giving in the second line, when we start DRTB treatment, we give high dose pyridoxine to prevent this from happening. We need to also let the patient know so that there's early recognition of these symptoms if it develops. And then we have to certainly, if there is, if this side effect happens, and we have to stop the causative drugs. And when we stop the culprit drugs, I think it is equally important to make sure that the regimen doesn't suffer, and readjust the regimen so that the treatment continues adequately. So I think these are the things for any side effects caused by any of these drugs.
So, what would be the high dose pyridoxine that we're using, Dr. Bornali?
So I think 100 milligrams pyridoxine we use in the DRTB patients, whereas in the first line, in the regular one, we use anything between 20 to 40 milligrams. 20 milligrams is standard.
The other drug is the levofloxacin, which also causes it.
The causes, okay.
Yeah. So my last question goes to Dr.
As the dose of the pyridoxine, Manoj, there are two types of dosing. One is that for prevention of neuritis, especially when if I using isoniazid or other drugs like linezolid, then the dose is little less, maybe 10 to 50 milligrams. But when once somebody has developed some signs of neuritis, and then probably dose has to increase to even 200 to 400 milligrams. So that was the conventional teaching in our time.
Can I come in for
but another issue I want to raise, when linezolid was not used in anti-TB drug, with the INH, the incidence of the peripheral neuritis is not very common. It's a rare. It is only seen in people who are malnourished, where there is an initial deficiency, if he is a diabetic. So all those things you have to look for, and then you have to think for peripheral neuritis.
Just a quick, can I come in for the dose of pyridoxine?
Yes, please.
Yeah. So the NTP recommends different doses of pyridoxine. For pediatric cases, it is 10 mg per day. For immunocompetent adults, it is 25. In high risk cases, we give this. For HIV patients, it is 50. For DRTB, it is 100. If a DRTB case develops this peripheral neuropathy, then increase the dose to 200. However, the dose should not be increased more than 300, because pyridoxine can also cause paradoxical peripheral neuropathy. In the second line drugs, pyridoxine dosing is based on the dose of cycloserine. 100 milligram of cycloserine, 50 milligram of pyridoxine is generally advocated. So the guidelines give normally 100 mg of pyridoxine. Thank you.
Thank you, Dr. Gyanshankar. That brings to the last question of the session today, and I would request Dr. Sameer to answer this. He's a great clinician and critical care specialist. So, pyrexia of unknown origin, PUO, and upfront ATT started. Is this the right practice, Dr. Sameer?
I think you asked a very valid question, because all across, in fact, today itself, we have this lady with transverse myelitis, who has been intubated, fever going on. There have been some cavities on the CT scan. They have done a BAL, it's all negative, but still she's on ATT. So this is a situation because she continues to have some low-grade fever. So of course, many times we do come across all these things. Putting on empirical ATT, definitely not justified. And as we always say, if you get a chance, please get the tissue. And nowadays it's not, it's not difficult. Possibly with the advent of intervention pulmonology, intervention radiologists, intervention in mostly every field, I think you can definitely get that tissue. And so again, yes, maybe a lot of people we have seen, they do Mantoux test, the typical in skin test, they may do IGRA, they may say positivity, and they may again start on ATTs and all. But again, as we have discussed all through the night, not really a great strategy, because these are not specific tests. These are not definitive tests to rule in tuberculosis, or rather, diagnose tuberculosis. They're only adjunctive tests. And whenever possible, please get a tissue or some sort of a sample for those microbiological or molecular tests. So upfront ATT for PUO, not really such a great strategy. I think that would be my opinion. Others can weigh in also.
Right, Dr. Sameer, and pyrexia fungoides require extensive investigations, and most important, you must do a thorough clinical examination. You may find some nodules on the back of the chest or maybe under the hairline, which may be due to sarcoidosis. Okay, these need a good physical checkup, and then they may require autoimmune checkup, and then some of these patients may still require the PET CT scan, maybe whole body MRI, and try to find out the source and then try to take a tissue from there or any kind of diagnostic material. So empirical ATT in PO is not justifiable in this modern era. This might be true maybe about 40 years ago or 50 years ago, but it's not the right thing to do. So I think we have exceeded time by about 40 minutes. I don't have time to summarize whatever I said, but our experts have elaborated, quite extensively on the various complexities in the management of tuberculosis. And for me, this has been one of the most informative learning sessions on complexity in TB management. I think all experts from the bottom of my heart who have guided us on the real world complex clinical scenario by sharing their vast knowledge, experience, wisdom. I once again thank Dr. Sandeep Salvi, Dr. Amita Nene, Dr. Rajendra, Indian Chest Society, CIPLA, BD for organizing this certificate course. I also thank USAID, Union National Tuberculosis Eradication Program pledged for their partnership. I also thank all the attendees from all over India for their active participation. And with this, I end this session and say goodbye till we meet again. Thank you very much.
Thank you. Thank you, everyone. God bless you all.
Thank you, sir. Thank you. It was really indeed. Thank you, sir.
Thank you. Really great. Thank you.
We are offline now. You all can communicate among yourselves.
Thank you.
Thank you.
Thank you.
Namaste, sir. Thank you. Thank you very much.
Namaste, Manoj.
Thank you, sir.
Well done. Very well done.
Good to have you on board, sir. Learned a lot. Thank you so much, sir. Thanks.